Okay, ladies and gentlemen, I think we can start right now. Good afternoon, everyone, and welcome to the session. My name is Eva Husnohotima. I am Health Financing Specialist at ThinkWell's USAID's funded health financing activity. We are very pleased today to have the opportunity to organize and present to you our session entitled Challenges to Establish Sustainable Health Coverage. How can different LMIC models in Asia teach us? We know that many countries is striving to achieve sustainable universal health coverage, especially in the face of hard challenges such as the COVID-19 pandemic. And in the case of Sri Lanka, in addition to that, they also faces national financial crisis. Sri Lanka is one of the countries that is going to present their experience today, in addition to Indonesia, the Philippines, India, as well as Indonesia. And we have an incredible list of speakers today. Slide, please. Yes, from Indonesia, we have Prof. Hasbullah himself, who is Chief of Party of health financing activity. Prof. Hasbullah has been very instrumental in advocating as well as developing the Indonesian National Health Insurance. We also have Prof. Ali Gufron Mukti, who is the President Director of BPJS Kesehatan, who is the administrator of the Indonesian National Health Insurance. We also have Mr. Budi Tambubulon, who is representing two organizations today, which is the Mandiri InHealth, that is one of the largest health insurance company in Indonesia, and the Indonesian Life Insurance Association. And last but not least, we have Ms. Anastasia Susanto, the Health System Strengthening Lead of USAID Indonesia. And from WHO Sri Lanka, we have Dr. Chatura Wijayasundara. From Protect Health Philippines, we have Dr. Carlo. And then from USAID India, we have Dr. Anuradha Jain. So without further ado, let me introduce you to our moderator today, Dr. Shabana Haider. Welcome, Dr. Shabana Haider. Dr. Shabana is the country director of ThinkWell Global in Pakistan, and Dr. Shabana has a vast experience in health financing, population, and nutrition. She has a double master's degree in global health as well as in policy and governance from McMaster University, Canada. She is an avid traveler as well as an ardent horse rider. So Dr. Shabana, the floor is yours. Thank you.
Thank you so much. Thank you, Eva, for your kind introduction, and a very good afternoon, ladies and gentlemen. I know it's very difficult to be awake in an afternoon session, but I hope the speakers will be able to jolt you to their presentations, and I hope we have a very good learning session today. And as Eva said, this session is further divided into three different sessions. The first session, which comprises of 3 speakers, it will give you a general overview of UHC and health financing, followed by a presentation by Priya on pandemic fund, which will help in external financing for those countries which have gone through a very bad COVID. And then finally, we have the Sri Lankan experience, because Sri Lanka currently went through two health system shocks. One was the pandemic, COVID-19, and then the unprecedented economic crisis that Sri Lanka is going through. So that's the first session. The second session will be primarily based on Indonesia's experience for health insurance, followed by the role of the private sector introducing out-of-pocket expenditures. And finally, we have an amazing panel discussion in which we have speakers talking about health system strengthening the opportunities and challenges in the aftermath of COVID-19. So please bear with us. And before I start, just some housekeeping rules for the speakers and for all of you. Please switch off your mobiles to silent. We would not want to disturb the speakers. The speakers have a 10 minutes limit to their presentations, and it's strictly enforced. So we will be having a placard displaying the last 1 minute for you to wrap up. Because we'll have to keep the time on time, and then the first session will be followed by a 30-minute break for discussion and question and answer. So please hold your questions for the first session after the 3 speakers are done, and similarly for the second session and the third session. The first session after the discussion will have a 10-minute coffee break, and that happens also after the second session. So let me start and just start with the thing that the SDG target of achieving universal health coverage aims to reduce inequity and also financial hardship for all those who want the health care. So the U in the UHC, which carries a lot of dimension, is the universality of it. It has a strong equity dimension and a mandate to focus on access for the most poor and the vulnerable. The whole session today focuses on the lower middle income country models and cases, and we're focusing on 4 major countries today: Indonesia, India, Philippines, and Sri Lanka. So these 4 case studies they'll be presenting on how these countries are financing health, and what has improved, what has not improved, what is required, and challenges to achieve universal health coverage. All of us, all of the countries around the world are advancing towards UHC to achieve the UHC goals. So, and everybody knows, I'll just give you a flavor of all the countries. Philippines has integrated social health insurance and assistance program. India has 500 million people who are covered in their social health insurance program. And Sri Lanka implemented a traditional national health insurance program like 50 years back. And while Indonesia has one of the largest single-payer health insurance program in the world that covers around 90% of the population. I'll stop here and I'll have more flavor to add when it comes from the field, from the countries themselves. And my first speaker of today is Professor Dr. Hasbullah Tabrani. He has been working in the field of health economics, including health financing, for the last 3 decades, quite well recognized in the country. He has been instrumental in developing the National Health Insurance Scheme, the JKN, and has, with strong elements of strategic purchasing. He is currently serving as the chief of party for the USAID's health financing activity in Indonesia. And he is also been served in different capacities as a senior health financing advisor to the National Security Council. And he studied in UC Berkeley. So Dr. Tabrani, please, a very warm welcome to you, and thank you for your time. Over to you.
Thank you. Should I stand here?
Yes, please. Do you want a microphone or do you want to stand here?
Yeah, maybe that's fine. I couldn't see well for that. Maybe be easier to see my slide. Thank you, Dr. Sabana, moderator, and good afternoon. Hopefully also we can wake, although maybe some of you are hungry because I didn't see you took lunch after the previous session here. I will address this financing issue preferably to provide some kind of rational background for health financing, especially for the next session where our colleagues in Indonesia will present the Indonesian case. Next slide. Next slide. Okay. First, I think we make understandings of the universal health coverage. Many of Indonesian, especially, I don't know, in other countries, often thinks that universal health coverage is national health insurance. It is not. As described here by the WHO, universal health coverage is not only providing health insurance coverage, but also including promotive preventive services. Yeah. So that's the definition of universal health coverage. If we look at the SDG 2030 target, it's only 6 years from now, very close. How far the country can achieve, that's one big question. Next slide. Just I want to give you some brief position of the countries presenting today. So Indonesia, Sri Lanka, and Philippines, and India. I'm sorry, India is not written there. Still quite far away to achieve universal health coverage. This is from the monitoring USC by WHO and the World Bank. So Indonesia is still in the between 40, 56, the indices. Next slide, just briefly. But not only the current position, we can check how the country progressing to achieve universal coverage with these indexes. Indonesia is quite aggressive if we look at the change, although at the previous slide, we are not in the highest level behind China, but the progress quite good. That's because we just introduced, later Pak Gufron will talk about the JKN. India also quite good in achieving this progress. Yeah. Unfortunately, sorry, Sabana, I forgot to take the Pakistan progress. Yeah, but not far from that. Next slide. If we look at the correlation between the universal health coverage and funding, the funding for the universal health coverage come mostly from the public sector. Yeah, the public meaning all the fund coming from the mandatory contribution or tax funded. Social insurance contributions considered public funding. Yeah. We can see here, Indonesia 20 years ago spent only 0.5% of GDP in the public funding, meaning the government funding and the social insurance or national insurance contribution. In the 2020 increased to close to 2%. If we look at the proportion of the public funding, 2% of current health expenditure, our funding also increased quite significantly. So the change is the highest among those 4 countries that we are discussing today. So that's a good achievement for Indonesia. Next. The public funding is the response for the healthcare need that is uncertain. This is why there is no kind of self-funding or out-of-pocket funding can achieve USC. It must be third-party payment because of the uncertainty of the healthcare. The response to uncertainty is insurance mechanism or public funding because we never know when we are having the need for healthcare and when and how much money and so on. So, and therefore must be a insurance mechanism or the party coverage, including the state funding. That's also in terms of covering, it is also kind of generally similar to insured, insured by the state. Yeah. That's the case for Sri Lanka, for example, or Malaysia. Next. This is the reason why most of the financing in developed and higher income countries rely heavily on public funding because of the unique characteristic of the healthcare, which is uncertainty of need, high information asymmetry that require control of the government, externality that require subsidies of public funding, and also the issue of human rights. You don't provide healthcare. Yeah. And therefore, if you look at the profile of financing all over the world, normally public funding is dominant to achieve universal coverage. Public funding meaning general tax funding from the income tax or from the some of state revenue, such as in Saudi Arabia or Brunei. No contribution, no tax, but natural resources enough to cover everybody. Or the last one is social insurance mechanism if we don't have the two model. Now, Indonesia tax funding system, yeah, not good. Yeah, so we use the social insurance system. Next slide. This is the challenge. If the funding from the public, what is the room for the private sector, whether the private sector can contribute or ignore. The private sector has problem. Certainly, if we rely on private sector will not achieve universal health coverage. Yeah, but private sector has some role in fulfilling the demand. The need must be fulfilled by the public funding, while the demand can be fulfilled by private or voluntary health insurance. The private sector will not be able to fulfill the needs for everyone. Yeah, so you can read later on. Yeah, next slide. So this is the best practice. If we look at the high income and upper middle income countries, the majority of funding coming from government or domestic funding, such as from tax or social health insurance. Yeah, in lower middle income countries, the out-of-pocket still the majority. So they are shift from the out-of-pocket to tax funding or social insurance. Next slide. Here is the map about public funding, public expenditure to total or current health expenditure. You can see here in Africa, they are mostly like behind. In Asia, also most of the countries here still inadequately fund their public their healthcare from the public sector. Yeah, but American continents relatively much better. Europe certainly already achieved. Australia already achieved. Next. Okay, I just next slide. I ran out of time. Next. Here the evidence of market failure. If we look at the US financing from the current health expenditure to total GDP, where dominance private or voluntary health insurance, the spending increased significantly since 60 years ago, while these countries with dominance tax or social insurance relatively have much better control. Yeah. Next, almost done. Yeah. This is another evidence comparing the outcome of life expectancy and spending. Those countries with public funding perform better. Next slide. The last one. Commercial insurance failed because of the commercial insurance certainly cannot cover the elderly. They will not cover insurance for the elderly. Commercial insurance will not cover existing condition, those who already suffer from well, maybe a congenital disease or suffering hypertension and so on. The nature of sedikit lagi. Yeah, sorry. Yeah. And therefore we have to focus on the public sector, but we give them room for private insurance to meet the demand, the want, yeah, because private insurance better in serving people, making people more satisfied with the services. Yeah. Next. Since there's conclusion, I think you can conclude yourself. Or we discuss. Thank you, Tabrani.
Thank you so much, Dr. Hasbullah. I think the main takeaway from your presentation, when you set the stage at the overall global level, is that when I see your presentation and see your maps, one thing is clear, this data is till 2019. And a lot of it varies, the UHC index varies between 40 to 69, as most of the countries, the LMICs that we're discussing today. And I think this data might be challenged quite recently because after the aftermath of COVID, a lot of things have changed and maybe we have just moved down. So just to advance this discussion that for UHC, we still have 6 years, that's not enough. And maybe some of the countries have been pushed down due to COVID and their UHC index or their coverage rates have further deteriorated. So it's a right call. You also talked about of different health financing mechanisms and how just one approach, a single approach cannot work in countries around the world because there has to be a mixed health financing approach to cover everybody, all age group, to ensure equity, etc. I move to my second speaker for today, and she is Ms. Priya Basu. She is the executive head of the Pandemic Fund hosted by the World Bank. Prior to this, Priya served as the head of the COVID-19 task force at the World Bank and led the bank's engagement on pandemic prevention, preparedness, and response. She managed a portfolio of more than $21 billion, so that's a lot of money, and to support partnerships around global priorities. And she was the inaugural head of the Women Entrepreneurs Finance Initiative at the bank. And she's also she has also worked as previously as at the International Monetary Fund. So that is most important in the case of Sri Lanka and Pakistan right now. So I leave this to Priya. Priya is traveling. She's, short of time also. So Priya, thank you so much for your time and patience. And we are eager to listen to you. She's basically talking about the pandemic fund, which funds, the external financing for countries, because, there's a health financing gap. The countries have been pushed more down the poverty, line. And to achieve UHC, you would always need external financing. So she'll be talking more about the pandemic fund. So over to you, Priya.
Thank you so much, Shabana. And hi, everyone. Perhaps someone could put my slides up. Would that be possible? Sorry, I'm having trouble hearing you. Are my slides being put up? Great. Okay. I see they're up.
Okay.
Very good. Thank you. So we can move on to the next, please. And the next, please. All right, great. So, as was mentioned, COVID-19 exposed a lot of weaknesses in health system strengthening more broadly, and also in the capacity of countries to respond to pandemics. And so, in response to the lessons that were learned from COVID-19, the international community felt that there was the need for a new multilateral mechanism to help low and middle income countries strengthen Pandemic Prevention, Preparedness and Response Capacity, PPR, if you'll allow me to use an acronym. And together with the WHO, we at the World Bank prepared an analysis for the G20, which was during the Indonesian G20 presidency, on how much it would take, how much investments were needed to build core capacities in low and middle income countries to strengthen PPR. And we estimated that about $31.1 billion per year over the next 5 years would be needed, of which about 2/3 would need to come from domestic financing and about 1/3 from external financing. So about 10 billion per year from external financing over the next 5 years. The pandemic fund against this backdrop was established as part of the solution to provide this external financing for PPR to low and middle income countries, complementing existing financing arrangements. And in the lower part of the slide, you just see a brief history of the pandemic fund. So it was established as a financial intermediary fund in the World Bank last June. And then we moved very quickly between June and September to get its basic structure in place, working with the group of founding donors, WHO, World Bank, and other partners. We then launched the fund officially at the G20 finance ministers and health ministers meeting in Bali, Indonesia last November. We have already mobilized $2 billion of resources for the pandemic fund from 25 donors, including 22 sovereign donors and 3 philanthropies. In March this year, we issued the first call for proposals, which closed last month. And as we speak, we're in the process of reviewing those proposals, with the funds were expected to be allocated to the first round of projects at the end of this month. Next slide, please. So what is the mission of the Pandemic Fund? It is to develop capacity within low and middle income countries in PPR by providing a dedicated stream of additional long-term grant financing for critical PPR functions in 144 low and middle income countries that we refer to as IDA and IBRD countries that are eligible for receiving money from the fund. And to support and reinforce capacity building of PPR under the IHR 2005, as well as other legal frameworks consistent with One Health. So our vision and business model of the Pandemic Fund really provides an opportunity to do things differently. And I just want to highlight a few key features of our business model. One, it provides the flexibility to deliver support to countries through existing institutions. So we don't make direct investments. We pass on money, we channel the money through an existing group of multilateral development banks, the WHO, other UN agencies like UNICEF and FAO, global health institutions like Global Fund, Gavi, and CEPI, to complement their work and drawing on their comparative advantages. Secondly, we're a catalytic mechanism. For every dollar of grant financing that the Pandemic Fund provides, we catalyze co-financing from these group of entities that I just mentioned, these global health institutions. And we also incentivize countries themselves, the receiving countries, to invest more in this space. So for example, when we provide grant money to MDBs as the channelers of funds, then the MDB loan gets blended with the grant. And so for the recipient country, they get resources at a more concessional rate than they would otherwise. The third feature that I want to highlight is that it really seeks to promote coordination among key agencies and actors working in PPR. We all know that the global health financing space is really siloed. There are many actors, there's a lot of fragmentation. So the goal of the Pandemic Fund is to promote coordination and integration at the country level, bringing actors together to support national action plans for health security. We also are able to mobilize funding from ODA and non-ODA sources. And we seek to serve as a platform for advocacy. Next slide, please. Next slide, please. So what is the scope of the fund? What are the kinds of activities? So as I mentioned, really at the, underlying all of this efforts on PPR is the need for stronger underlying public health systems. So we really recognize that, without strong national public health institutions, the necessary infrastructure, and sort of the necessary systems, then you can't really have a country that's ready to face the next global health crisis. Having said that, though, COVID has taught us that there are some areas that really need specific attention for pandemic PPR. And so those are the kind of areas that the pandemic fund focuses on. At the center of all this is strengthening country and local capacity in core IHR 2005 and WOA domains, such as building disease surveillance systems, laboratory systems, emergency communication, coordination and management, community engagement, and last but not the least, critical health workforce capacities. And the fund can also strategically invest in health systems at the community and primary healthcare level. Then on the left side, you see that we also focus on building regional and global capacities because, for example, for better surveillance, once you've built the community and local and country capacity for surveillance, it's also important to network this data up to regional and global levels. Similarly, building shared public health assets, good reporting and information sharing, regulatory harmonization, and then, of course, capacity to support the coordinated development, procurement, distribution, and deployment of vaccines, therapeutics, testing, other medical countermeasures, which would need to be done more effectively and efficiently at the regional and global levels than each country having its own manufacturing capacity. And then on the right side, you see technical analysis, technical assistance, analytics, learning, and convening. So those are kind of the areas of scope of the pandemic fund. Next slide, please. This just tells you that we have a very strong focus on an inclusive governance structure. We have the pandemic fund has its own independent board. The board is actually currently chaired by Dr. Khatib Basri, the former finance minister of Indonesia, and Dr. Saban, who is the health minister of Rwanda. The board contains 21 constituency-based seats that represent our contributor countries, all of what we call our co-investor countries, who are the countries that can benefit from pandemic fund resources, our contributor philanthropies, and then we also have 2 seats for civil society. And we have a strong focus on transparency and accountability and sort of shared responsibility that's needed to address such an important global public good, such as pandemic prevention and preparedness, where really no matter where you invest, it benefits everyone. So you can invest in PPR in any corner of the world, but the entire world is likely to benefit from that. And as we saw from COVID-19, if you don't invest, the fallout is tremendous. The trillions of dollars of output lost to the global economy could have been averted with, a few billion dollars of investment per year, as we've shown in our analysis. Next slide, please. This just gives you an overview of the operating arrangements. We have this governing board, as I mentioned, with the secretariat that's hosted by the World Bank. We have a trustee. We also have a technical advisory panel that's chaired by the WHO, which has the task of evaluating all the funding proposals that come to the pandemic fund. And then we have the lower part of the slide, you see, we have all these implementing entities, MDBs, UN organizations, etc., that channel resources to beneficiary governments, as well as regional and global organizations. Next slide, please. You can click and move to the next, please. Yes. So this I'm coming to the end of my presentation. As I mentioned, we we announced our first call for proposals in March, and it closed in May. It had 3 areas of focus: the disease surveillance, lab systems, and human resources for health. We issued the call to all our 144 eligible countries, as well as regional organizations in those countries, regional organizations representing those countries. We invited these proposals. We received 179 applications with proposals involving 129 countries and requesting $2.5 billion in funding, even though the envelope for the first call was only about 300 to 350 million because it's meant to be a pilot. So it was 8 times oversubscribed. Through the first call, we saw strong country and regional commitments to strengthen pandemic PPR, both monetary commitments where possible, as well as non-monetary commitments and policy commitments from countries where fiscal capacities are stretched. We saw a strong emphasis on One Health, showing an appreciation of the interplay between animal and human health and the environment. And there were also many proposals that focus on cross-border collaboration in strengthening PPR. So, the big message is there's really enormous demand and strong interest from low and middle income countries to step up investments in pandemic PPR. And yet, in the face of multiple crises, including climate, debt, food security, rising poverty, many of the poorest countries simply don't have the fiscal space to make these investments. Just to share, according to a recent World Bank report, we found that government spending on health in many of these countries has already dropped since the height of the COVID pandemic. So really to underscore that in this situation where demand is high, but fiscal capacity is very stretched, the need for additional external financing, especially grants, is ever more important. And so we really see the pandemic fund was set up as a proof of concept, and I think the concept has been proven. The demand for the fund is really high, this is just the beginning. We did the first call for proposals. The money will be allocated at the end of this month, but we'll be issuing subsequent calls for proposals over the next years in order to help countries get better prepared for the next pandemic. As the WHO has said, it's not a question of if there'll be a pandemic, it's a question of when the next pandemic will happen. Climate change and so on are key drivers of pandemics, and the probability of the of a next pandemic happening has been predicted to be pretty high. So we very much look forward to working with all of you. Many of the countries represented here, some of you sit on our board. All of you are eligible to receive money from the pandemic fund. We are committed to learning along the way and improving the way we operate. We have a huge task ahead of us as the only dedicated multilateral financing mechanism to strengthen PPR. Our vision and mission is pretty unique, and we're excited to deliver on this promise. Thank you so much for your attention.
Thank you very much, Priya. Thank you very much, Priya. And I think the Pandemic Fund is a great opportunity for the LICs and the LMICs, as Priya said, because the government spending has decreased in the aftermath of COVID-19. And this is a way for external financing to help achieve and advance UHC. Nevertheless, when we deep dive in the discussion, Priya, I would really want to understand the performance levers for this kind of a fund, and how does this grant translate into important outcomes? Because generally what I've seen in practice, the grants and even external financing has really not helped, and it has made the countries more vulnerable and in fact increase the debt burden. So more to discuss that in the discussion session we have. We have the last presentation for this bit of the session, and it's a very interesting case, the case of Sri Lanka. And I'm very happy to invite Dr. Chatura Rasika Vijay Sundra. Thank you, Dr. Chatura, for being with us. Dr. Chatura is working as the National Professional Officer in Health Economics and System Analysis at the World Health Organization office in Sri Lanka. He is also functioned as the national consultant in the knowledge management and monitoring for WHO. He's a doctor, he's a medical doctor and is quite well accoladed. I see all your gold medals and awards. Congratulations for that. And young budding scientists, I request you to come here, and Dr. Chatura will be talking about the Sri Lankan experiences and the significant health system and financing reforms in consideration of Sri Lanka, which is according to, everybody knows about the dual health system shocks, the prolonged COVID, and now the unprecedented unprecedented economic crisis. Over to you, Dr. Chatura.
Thank you, sir. Is working? Can you hear me? Good afternoon, everyone. So my job today is to talk about the Sri Lankan experience, to talk about the dual health system shocks that Sri Lanka is currently facing. Of course, the dual health system shocks, what I'm referring to here is the COVID-19 global pandemic. Of course, all countries face that. But in the case of Sri Lanka, specifically in terms of the economic and the financial crisis, currently that Sri Lanka is experiencing. Next slide, please. So Sri Lanka is a small island nation with a population of 21.4 million. And Sri Lanka is currently a lower middle income country. Next slide, please. So if you talk about the Sri Lankan health system, so Sri Lankan health system is a system which provides health services free at point of delivery. And mainly it's provided by the government. Of course, the private sector is present as well, but mainly majority of the preventive services as well as 50% of the curative services are provided by the government sector. And Sri Lanka has been a model country where strong health outcomes have been achieved over the years, especially in the case of reproductive, maternal and child health, as well as communicable disease control. So the main reasons for this achievement is the strong supply side efforts that have been taken based on the primary healthcare approach, where services have been provided free at point of delivery with good levels of access. Next slide, please. So you can see when you compare Sri Lanka with other low middle income countries, the achievements have been quite significant. You can see if you look at life expectancy at birth, maternal mortality ratios, infant mortality ratios, Sri Lanka has done well compared to the other low middle income countries. And when it comes to communicable disease control, again, significant achievements are there. Next slide. So all these have been achieved with low levels of investment. So Sri Lanka has achieved strong health outcomes over and above what is commensurate with its income level. So the government spending is about 2% of GDP, it's about 1.8, 1.9. So general tax revenue is what funds the health system. And of course, the out-of-pocket expenditure is going up and is about almost 50% now. However, the catastrophic health expenditure remains low at about 5%. So this is how health is financed in Sri Lanka. Next slide. So the same thing as you can see. So when you look at the sources of health expenditure, it's mainly the government transfers and the out-of-pocket spending. The levels of health insurance coverage is quite low, and the reliance on external aid is quite low as well. So if you look at CHG as a percentage of GDP, as I said, it's about 4%. Next slide, please. However, although there have been significant achievements in the areas of RMNCH and communicable diseases, Sri Lankan health system was facing challenges even before COVID-19. So this is in terms of providing services for non-communicable diseases. So Sri Lanka is one of the fastest aging populations in the world, and provision of services for non-communicable diseases as well as the aging and disabled population has been a challenge. Next slide. So Sri Lanka was thinking about health system reforms even pre-pandemic. So in 2018, a policy was developed, which was known as Policy on Healthcare Delivery for Universal Health Coverage, which looked at a service delivery reform, where the curative care network was to be restructured, where primary care institutions would be linked to a specialist apex hospital. And the population would be empaneled to this primary health care institutions so that there would be a family doctor who would be responsible for the empaneled population. However, although this structure was envisaged and adopted in the policy, it was not fully operationalized because of the first shock that I was talking about, the COVID-19. Next slide, please. So of course, this is the situation in Sri Lanka with more than 600,000 cases and 16,000 deaths. You can see very significant two peaks coinciding in the Alpha and the Delta wave in the country in 2021. So quite significant impact to the health system where it had affected the essential service delivery as well. So this is the first shock that I was talking about. Then moving on to the second shock, next slide, the economic crisis. So Sri Lankan economy grew until about 2017 to 18. Then of course there were multiple shocks. Of course, Sri Lanka underwent Easter bombing attacks in 2019. Then of course COVID-19 and the economic crisis. So economic crisis from 2022 onwards has had impact on the overall economy, with the economy contracted by about 9% in 2022. So one of the major issues that we have had is that the government revenue and expenditure. If you can move to the next slide, you can see the difference between the revenue and the expenditure, the fiscal deficit, and the debt percentage is well over 100%. Next slide. So with the economic crisis, of course, there were major issues with government announcing debt repayment moratorium, and foreign exchange liquidity constraints affected all supply chains, including supplies for health. So then inflation reached almost 70% at one point. So unprecedented levels in Sri Lankan context. And of course, Sri Lanka now have got an IMF executive board approved extended fund facility of about $3 billion to support the economy. Next slide. So you can see the official reserves depleting and how the poverty rate has increased. Next slide. So implications for the health sector. Of course, the economic crisis has had severe implications on the health sector as well. Insufficient resources for health sector affecting the supply chains. So there were shortages of medicines, supplies, as well as equipment. All those problems were there. And of course, this would have impacted the out-of-pocket expenditure as well as catastrophic. We don't know, we don't have the information as of yet. Currently, government is conducting a survey in order to identify that. And of course, human resource out-migration, another critical issue. So we see a large exodus of nurses, doctors, as well as other medical professionals migrating out of the country. Next slide, please. Yeah, you can move on. So this shows the situation in the country last year. So this is about the medicine shortage. Next slide. Yes. So what is the crisis? What is the response to the crisis? Winston Churchill once said, never let go of a crisis. So this could be an ideal opportunity for us to talk about health system reforms. So in Sri Lanka, although there has been discussions of service delivery reforms, the appetite for health sector reform, broad reforms, is minimal. Because still, we think that the Sri Lankan system is doing well. So the issue is, why try to mend a system which is not broken? But the economic crisis has suggested that this may be the ideal opportunity for us to consider in terms of health sector reforms. So business as usual is no longer an option for the Sri Lankan health system. So we are looking at two critical adjustments, getting more money for health, and of course, more money for the health system. Health we have, that is in terms of system efficiency. Next slide. So what have we done in terms of mitigation measures? Of course, government has prioritized health and education. So there has been increased allocation to the health sector, especially for the recurrent expenditure. Then, of course, the UN and the development partners have come together to provide a coordinated mechanism to address the supply chain shortages. And some of the loans that was for the primary care strengthening have been repurposed to a certain extent in order to address the supply chain shortages. Next slide, please. And of course, there has been renewed focus on maintaining primary healthcare services, including preventive healthcare, and focus on vulnerable populations, because currently poverty is increasing, and focusing on vulnerable populations is important. So National Emergency Nutrition Plan was developed with that aim. Next slide. So in terms of medium-term, long-term effects, so WHO has been supporting the government in terms of looking at evidence generation to highlight policy action which is needed in the context of dual health system shocks. So we are looking at other countries' best practices to see what could be applicable to the Sri Lankan context. So also Sri Lanka is a country which does not have a health financing strategy. Now we are in the process of developing the health financing strategy for the country. And of course, at the highest level of the government, there is an increased interest about improving efficiency. So these are some of the key activities that are happening. Next slide. So you can move on to the next slide. So these are some of the work that has been done looking at best practices from other countries, looking at service delivery, HRH, health financing, to generate evidence as an advocacy tool. Next slide, please. And of course, it's most important to bring all stakeholders together. One of the things that the crisis has brought is that the Ministry of Health and Ministry of Finance are sitting together and talking about how the health system should be financed. So in this diagram, you can see there's a health, this is a consultation that we had about 2 months ago. We have the Health Ministry, the Ministry of Finance, the private sector, academia, and international experts from Thailand, Indonesia, South Korea, all sitting together and discussing in Sri Lanka about what could be the best practices in Sri Lanka. Next slide, please. So political advocacy is the key. You can see the health ministers. Go on, please. So the former president of the country also participating in these discussions. Next slide. Next slide, please. So learning from best practices, we are looking at other countries. So today we are talking about Philippines. So this is the Sri Lankan delegation, which includes the health minister, the finance minister, which is visiting Philippines in support of the ADB. And of course, we are looking at these sort of high-level visits to other countries as well, like Indonesia and Thailand. Next slide. Next slide, please. Move on. So finally, the discussions are ongoing and we are looking at potential recommendations. We are thinking globally and trying to act locally to see what would be the relevant recommendations to Sri Lanka. So in the short term, it is about protecting the vulnerable population, ensuring that people are not pushed towards poverty. And of course, I said Sri Lanka was not reliant on donor funding, but maybe in the short term, we'll have to look at external funding as well. Next slide. So looking at the adaptive responses, maybe over the next 5 years, we have to think about getting more money for health. So this could be through the general taxation mechanism that we are using, and maybe considerations of earmark taxation, which Sri Lanka has not tried before. And of course, looking at increasing the fiscal space for health by improving efficiency. Last slide is about the long-term response, that is the transformative response. So here, again, broad health sector reforms will have to be considered in terms of improving efficiency and accountability in budget allocations, moving from input-based budgeting to program-based budgeting, and of course, considering other potential options such as strategic purchase. Thank you.
Thank you so much, Dr. Chatura. So I didn't know the Chinese use 2-stroke brushes for the word crisis. The first stroke is for danger, depicting danger, and the other stroke is for opportunity. So in a crisis, we need to be aware of the danger, but on the other hand, it's also a great way to recognize the opportunities as Sri Lanka is doing right now. And let me tell you, Sri Lanka is a country that spends low and has very good positive health outcomes that we have seen. And I personally got to see the Sri Lankan health system when we faced dengue in Pakistan. And when we had a look at your primary healthcare system, it worked amazingly. We wish you well, and we wish Sri Lanka well to address this double shock that you're going through. And now this is the time for discussion for the panelists. So we've had 3 presentations. One talk, Dr. Hasbullah talked about a global overview of UHC and health financing, especially touch a little bit on the Indonesian system and the health financing that they're doing there. And then we have the pandemic fund that was taken up by Priya and how it looks into the opportunity for LICs and LMICs to access grants for the funding, which across has depleted around the global world. And lastly, we listened to the Sri Lankan experience. And I feel great energy, Dr. Chatura, that still, apart from the double shocks that you're facing, you're still geared towards moving your system in a positive direction. So I'll open up for questions and happy to take questions. If you have, please raise your hand, introduce yourself, and happy to, and please focus your question on the presenter for today. We'll start any questions? Yes, Matt. Who has the microphone?
Thank you.
Works.
Is that going?
Yeah.
Yeah. Okay. Dr. Chatura, nice to meet you. We've spoken on the phone. Matt Boxall from ThinkWell. I spent the morning in a session with colleagues, mainly from Africa, talking about the evolution of national health insurance schemes across Africa. And we've heard from Prof. Hasbullah about the JKN experience in Indonesia. I'm interested to hear your thinking about national health insurance in Sri Lanka. Was that part of your discussions, and judging by the conclusions, was not part of the sort of immediate solutions you're looking at, which sounds very sensible to me, but I'd love to hear your thinking on that and how the discussion went. Thank you.
Thank you, ma'am. So basically, it is part of the discussions, of course, in terms of looking at health insurance options. But for the moment, I mean, most of the stakeholders who understand in Sri Lanka, the situation is such that we don't have health insurance coverage in terms of social health insurance. I mean, there are certain mechanisms, but the coverages are very low. And of course, in terms of private health insurance, again, the penetration is quite low. So for the moment, basically what we are looking at is in terms of increasing money for the health through the government revenues itself. So the problems, and one of the major problems that we have had in terms of the overall economy is that the collection of taxes has been quite low. So taxation in terms of payroll taxation as well, the collection mechanisms are not all that great. So the revenue that is generated through taxes is quite low. And in 2019, the government took a decision to cut down on the taxes also. So the government revenue came down quite significantly. So that is considered as one of the major reasons for this economic crisis that we are facing, because the government revenue came down quite significantly. Now, all those issues are being resolved one by one. So the taxation has been increased. So the revenue, we are thinking that the revenue would go up. And with that, of course, in terms of the overall economy is improving, so the share of the health sector would also increase. And of course, we are thinking about earmark taxation also as a potential way of identifying fixed revenue for the health sector. So those are the main things that we are looking at, but of course, moving towards health insurance, maybe in the long run, could be a possibility. But at the initial stage, we are still thinking about maintaining the same structure.
Dr. Chatura, you can sit here.
As one of Sri Lanka's neighbors, I'm from Kerala, so I've always benchmarked Kerala's performance with Sri Lanka's. I'm surprised to say that you're planning health insurance, because 95% of your service provision is from the government. So it makes no sense to bring in a kind of purchasing the private sector if you're planning that. And I think the way Sri Lanka succeeded has been by strengthening its government sector. Just because of the financial crisis, we want to junk that overboard and then move to an insurance system. Whereas we've always looked at Sri Lanka as one of those models that has had a good NHS-like system, and I hope you'll continue with that. Thank you.
Just to add to that, so although 95% of the coverage in terms of curative care service provision is from the government sector, there is a very significant proportion of outpatient care which is provided by the private sector, which is more than doctors. Yes, dual practice is a major concern, but we see that there is a shift towards private sector as well. So those options are there. But as I said, in the initial phase of it, we are not thinking about insurance as a major option. So our options are in terms of increasing the government revenue, and through which we can finance.
Please.
Actually, my question, sorry, I'm Manjiri Balakar from the Gates Foundation, and my question builds a little bit on Rajiv. If I remember correctly, you said 50% of your outpatient services are in the private sector. And you're undertaking a health financing reform. So I was wondering if you could reflect a little bit on how you're looking to engage with the private sector providers. You mentioned strategic purchasing as well. So I'm curious to hear a little bit about that. Thank you.
So for the moment, both systems are functioning in parallel. So there is no interaction between the public and the private in terms of PPP models or strategic purchasing in Sri Lanka. But the key feature here is the dual practice that we see in Sri Lanka, where it's the government doctors who are actually functioning in the private sector also. So most of the private sector hospitals as well as outpatient clinics are managed by government sector employees, because government still provides employment for all doctors who are passing out from the state medical faculties in Sri Lanka. So this is where we are thinking of how to engage the private sector, especially in services which are difficult to be provided by the government sector, because now, especially in the major cities of the country, there is a booming private sector, and most of the services, especially high-end services in terms of, let's say, imaging services, like CT scans and MRIs, all those are available in the private sector. So this could be an opportunity for the government to develop some sort of public-private partnership mechanisms, because those services could be outsourced easily through a strategic purchasing model. So these are some areas that we are looking at in terms of potential avenues. And for certain areas in the country also, where there is private sector availability, so contracting in private sector may be a feasible option rather than the government trying to provide the services. Now, of course, one of the major issues that we have is the human resource out-migration. So we see some of the primary healthcare facilities are actually not having the staffing requirement that is there. So maybe that would be an opportunity for where the private sector can actually come in. But unfortunately, these models have not been tried out. That's why we are looking at other countries to see how these could be implemented in Sri Lanka. So this would require broader reforms in terms of developing the model as well as developing the institutional mechanisms, because currently it's the Ministry of Health who is the purchaser as well as the provider. So therefore, we need broader reforms in terms of institutionalization as well.
Any more questions? I have a question for Priya. So Priya, I was very interested. So you have this pandemic fund. What are the performance measures, as I was discussing, that you've kept for the countries? One, what is the criteria? Do you have a stringent criteria for them to access those funds? And the second is, how do you measure progress, or how do you measure success? Because, you know, generally I've seen that you dole out the money, no questions asked, and these grants are used for all kinds of purposes except health. So how do you ensure, and what are the performance measures for this pandemic fund? Over to you, Priya.
All right, thanks. Can you hear me? Sorry, I have moved to my mobile device because I'm on the road. But that's a good question. But you know, the pandemic fund is solely dedicated to pandemic prevention, preparedness, and response. So there's no risk there of the money going to other areas. So that's point number one. Point number two, they're grants only, so they don't add to the debt burden of countries, precisely because we believe that there's a need to invest in this global public good. So, you know, that's point number two. Point number three, there's been a strong focus on results, how to measure results. We have a very well thought out results framework. You can actually find it on our website. But just to summarize, we have a number of indicators using the JEE, the Joint External Evaluation Indicators of the WHO, as well as performance in veterinary services, PVS indicators, to measure, zoonotic transmission issues. And one very simple kind of overall measure that we are using to capture progress over time is something called the 717 indicator, which is 7 days to detect, 1 day to report, and 7 days to contain. So we can measure as we invest in countries to strengthen their capacity for PPR, we can actually measure progress on these indicators in the context of emerging outbreaks. So that's just to share a little bit, but please, I encourage you to have a look at our results framework. It really is a work in progress. So, we will adjust and improve it over time as we learn from our various rounds of funding. Thanks. Back to you, Shabana.
Thank you, Priya, for answering the question. I raised this question because we use some of the pandemic funds to upgrade our basic healthcare facilities, infrastructure, and, fancy facilities, and not IHR and other things. Anyways, any questions further? Any more questions? I have a question for you, Dr. Chatura. Sorry, I am very interested about the Sri Lankan case. And while we discuss things and everything from technicalities, what we really miss out is the political part of it, the political economy of those decisions. I am very interested to understand the political economy before and after what happened to Sri Lanka and how has it shaped the Sri Lankan health experience or the health system, the revised transformation in the health system? Because I think when you talk about health financing, a lot of it is depending on the political economy of the country. We miss out that great element in all our discussions, and we don't have a lot of research on that important element, because I've been working with the politicians in my country, and everything that I've studied goes to the basket when they decide on policies. It's not just evidence. So what is your take on the political economy before and after what happened to Sri Lanka?
To that question, so I think there is a drastic shift in terms of the political economy pre and post crisis. So I was part of the discussions in 2019 when Sri Lanka was trying to develop a health financing strategy. So this was driven by the health ministry and health ministry alone. So when we had discussions with the Ministry of Finance and other stakeholders, they wouldn't even participate in some of the discussions. There was hardly any interest in terms of looking at the health system reforms, how best health system could be financed, because it was function. But now, of course, the pressures in terms of the prioritization is actually coming from the Ministry of Finance. So the Ministry of Finance is the one which is mandating the Ministry of Health to come up with a health financing strategy and look at health financing options for Sri Lanka. So as I showed in one of the slides, the Cabinet of Ministers has requested a health expenditure review. So this is to be directly reported to the president of the country. So they are looking at inefficiencies in the system. So there is a significant shift, not only for health, but also for other areas also, to look at whether we are doing things right, and of course, how best we can correct. And in terms of the work that we are doing also, we identified that the importance of getting the politicians on board. So for all the activities that we are doing, we are trying to get advocacy at the highest level, from the president to the health minister to the Minister of Finance. Even the visit that I showed of the high-level delegation visiting Philippines, that is for them to understand the health financing mechanisms in Philippines and to see what would be applicable to Sri Lanka. So we want to drive the change at the highest level so that they would be the advocates for change, because ultimately, if we are looking at any health system reforms, it will have to be coming from the highest level itself.
Thank you. Do we have any further questions? Yes, please.
Hello, my name is Hassam Durrani. I'm part of Think West Pakistan team, Dr. Shabana's team. So my question is for Dr. Hezbollah and yourself, Dr. Chatura, because it sort of touches on both your countries. One of the provinces in Pakistan has rolled out universal health insurance 2 years ago. But Pakistan today is also going through an unprecedented economic crisis and trying to enter an IMF program. In your perspective, Indonesia has rolled out health insurance over the last 20, 30 years, and surely there would have been economic turbulences along the way. Today, the conversation in Pakistan is about scaling down the universal nature of it, or removing universal health insurance to perhaps some percentage of the population. What is your take and how do you see this as part of the broader economic challenges?
Dr. Hasbullah, first you, and maybe Dr. Chatura, you can respond later.
Yeah. You want to introduce an insurance scheme, whether social or commercial, make sure that before that people paying out of pocket and they perceive or they have kind of suffering paying a large amount out of pocket. If you are like in the Sri Lanka where you already have get access and then you introduce insurance, suddenly it's very difficult because people already used to pay with small amount of money. Even in, for example, in Sri Lanka, you mentioned in 50% outpatient of the patient are in the private sector, but the amount of money paying may be not catastrophic, and they don't feel like high risk to contribute for the insurance. So if your profits want to introduce that, make sure that before that they already have experience spending high amount or catastrophic feeling difficult. Otherwise, it's very difficult to introduce health insurance, social insurance mechanism. On the other hand, if you want to do the public funding, tax funded, if your tax ratio very low, certainly you will not be able to do it. you can provide care for everyone, but with quality might be not so much. And private sector will jump in later on when private sector quite big. Then this risk of healthcare needs increasing. Then you can introduce the insurance model. That's my opinion.
Nothing much to add from my end. Of course, in Sri Lanka, there are no specific areas as such which has different impact of the economic crisis, and the whole country has been affected. But we are focusing on vulnerable groups, as I said. So while trying to make keep the universality and make sure that health services are provided free at point of delivery, but in terms of vulnerable groups, there may be additional mechanisms would be needed in order to make sure that they do have access to healthcare services. So those are some of the things that we'll have to consider in detail in terms of how to cater to the vulnerable groups. So that may require other specific mechanisms, but overall, in terms of the overall health system financing, we still try to stick to the models that have been functioning well in Australia.
Thank you so much. Any more questions before we break out for our coffee break? That's a session for 10 minutes coffee break. Any further questions on UHC, broader questions on, we'll have a session of the Indonesian health insurance in the second session and the private health insurance in Indonesia. So that's all for the Indonesian session. And then lastly, we'll follow up with a panel discussion on health system strengthening in the aftermath of COVID-19. So it's 2:20 right now. We'll meet at 2:30 if that's okay with everybody. We'll have a short coffee break and we come back in the same room. And we'll meet at 2:30 for the next set of presentations. Thank you so much to the esteemed speakers. It was lovely having you.
Thank you very much.
Thank you so much, Priya, for taking time out, and we wish you a safe flight.
Not at all. And it was really very, very interesting to hear the experiences of Sri Lanka and Indonesia. So thank you very much.
Thank you, Priya. Good day. Bye-bye. Thank you so much for joining us back. So our second session is focused on the Indonesian experience. The first presentation in this session, may I kindly invite Professor Dr. Ali Gufran Mukti. He is the President Director of BPJS Kesehatan. I hope I'm pronouncing it right, the Indonesian Social Security Administering Body for Health, after being inaugurated by the President of Indonesia. He was the chairman, formerly the chairman of the COVID-19 Research and Innovation Consortium and acting expert staff of infrastructure in Ministry of Research and Technology. He has also been the former Vice Minister of Health Indonesia and the acting Minister of Indonesia of Health. And he's a guest lecturer in many world-class universities like the Harvard, and he took the sport health insurance courses in UCLA. That sounds very interesting. So Dr. Mukti will be talking about the achievements of the National Health Insurance Scheme in Indonesia. Over to you, Dr. Mukti. Would you like to stand there or would you like to stand here with the mic? So that you can see your presentation.
Okay. Thank you, Savannah. Hello? Yes. Okay. Test. Can I increase the voice? One, two. Okay. Thank you very much. As you know that the Indonesia is in Southeast Asia with more than 17,000 island, and then more than 13,000 islands are inhabited. with a total population reaching up to 275 million. So we are the fourth populous country in the world. These people do not know. Yeah. And although the India now is overtake China, this is applause for the India. I'm not sure Kashmir is India or Pakistan. Next slide. So of course, then people sometimes asking, where is Indonesia? And some people asking and said, so where is Indonesia inside Bali? So they know Bali rather than Indonesia. So previously, there are many schemes. We have at least 6 different health insurance schemes with more than 300 local government initiative schemes operating in Indonesia. Then each scheme had its own benefit package, payment system, and also had financing profession. Then, of course, trying to merge into one scheme. The question is, which one is better, contributory or non-contributory schemes? That is very difficult questions. But of course, we are not discussing which one is better, but how our experience in contributory schemes. When I was in England, so many people in England are surprised why you choose contributory. It was difficult to collect the contribution. So for the tax base, it's much easier. Next slide. So like in Sri Lanka, I think type of tax base in many countries are tax base. So that time, when we would like to merge into one single integrated comprehensive schemes, it was pros and cons. So next slide, I will not why they are cons, why they are pros, but one of the provocateurs here. Next, so now if we are comparing between Indonesia, Philippines, Malaysia, UK, US, those who are tax-based and contributory schemes, this is really amazing. I will not talk one by one. So for example, when we are talking percentage of GDP on health, Indonesia is around 3.3% or around 31 billion US dollar. US, for example, around 18% or 3.4 trillion. So it is huge difference. So around from the government budget for US is 980 billion. And Indonesia is around 16.9 billion. But what happened is the outcome. Life expectancy in Indonesia is 72, then in US is 79. Sometimes 76 is depend on the source of information. So when we are asking which one is more cost effective, it is again difficult to answer. Next slide. So now we already covered and achieved more than 255 million of the population as our members. And as we know that our population is 275 million. So that is around 92% of our coverage with more than 23,000 primary health care and 2,969 hospitals, and 64% of this hospital contracted to BPJS is mainly private. Next slide. Next slide. So, before that. Okay, so when we look at the Lancet written by William Seftoff, that in the world, when we compare the Germany, for example, to achieve universal health coverage, it took 127 years. And the fastest is South Korea, which took 12 years. Indonesia is 10 years. Now it's the 10 years. We almost achieve universal health coverage, although not yet, we're 92%. So it means 255 million people. Next slide. So this, if we, for example, experience and perspective.
Karena sepanjang hidup saya tinggal di Inggris, saya dilindungi oleh sistem jaminan kesehatan namanya NHS. Saya senang mengetahui Indonesia juga punya sistem kesehatan namanya LMIC. Karena punya sistem kesehatan nasional berarti semua orang boleh khawatir kalau sakit dan harus bayar tagihan kesehatannya mahal. Alhamdulillah saya sudah terdaftar di BPJS, itu saya lebih tenang karena saya dilindungi oleh BPJS.
Ya sayang, aku tahu kalau kita masuk di BPJS, cuma jangan lupa sistemnya itu beda dari Inggris. Kita harus membayar setiap bulannya atau menggunakan debit biar kita nggak lupa sehingga kalau kita semuanya itu terproteksi dan dilindungi oleh BPJS. Makanya jangan sampai percaya ya.
Ya, saya sudah tahu saya bisa baca di website ada bahasa Inggris juga tahu biar aku lebih mengerti.
Ayo, buat kalian yang belum punya BPJS, berulang segera daftar. Istri saya itu mau Inggris punya BPJS karena banyak banget loh benefitnya.
And for any foreigners like me out there who are interested to know more about BPJS, don't forget to check out the BPJS website. They have lots of information on there ready to go.
Okay, so the foreigner who reside in Indonesia for more than 6 months are required to become JKN participants. Next slide. So the think well personnel who working in Indonesia for more than 6 months should register. And this is the contribution. So for those who are having salary, the employee should pay 1% and the employer 4%. And for informal sector, it depends on what they are choosing. Next slide, for self-employed. And about our asset, because since it was established in the year 2014, we always deficit, but now we are positive, but still not too much positive. It is in the, still healthy, our asset, less than 6 months clean. Next slide, please. So what we are, achieving, we are following the policy changes. First, that now we have no more deficit, no more debt in hospital, and we introducing payment in advance to the hospital, and of course, increasing tariff. So previously, like in UK, the doctors are a little bit sad and not happy, but now they are happier. Still, some are not happy, but happier. And of course, we are efficient, and 2 forms of transformation actually what we are doing now. First, BPJS Kesehatan structural transformation, we establish a specific department responsible for quality administrative services and health services for JKN beneficiaries. Okay, and then BPJS Kesehatan cultural transformation. Then we also build massive digital ecosystem. So this important thing, strengthening and emphasizing health promotion, prevention, including screening for certain diseases and consultation. And we use PCare for COVID-19. So it is very lucky we have PCare already contracted with more than 23,000 primary healthcare facilities. Otherwise, Indonesia have very difficulties to vaccinate our population and to trace and so on and so forth. And we now have iCare. So what is iCare JKN? Next slide. So iCare actually is innovation of BPJS Kesehatan, integrated health services history, and innovation to help the medical doctor to healthcare provider in improving diagnosis, because doctor will be able to see patient previous diagnosis, treatment, visited healthcare facilities, drug allergy, etc. And all patient JKN members are able to bring their medical record in their hand. It is quite, in my opinion, quite innovative, because with their own username, password, informed consent, encryption with medical record can be seen by the medical doctor. Next slide. So this is the, how BPJS Kesehatan develop innovation solution. So there are many things actually on the bank, with the government, with academia, with stakeholders, with health facilities, too many things if I explain this. So next slide. So yeah, next slide. So therefore, because of this innovation, and ISA is International Social Security Association, we work together with ISA and
Yes, now dinner can be announced. So I would like once again to congratulate all member institutions who took part in the competition. It was impressive to see the range and the scope of the submissions. The one award we have not yet announced is, of course, the overall winner. So, from 168 entries in the jury had to select one that was outstanding and deserved to be awarded as the winner of the competition. So it is my great pleasure to announce the winner of the Easter Good Press Award for Asia and Pacific for 2021. The winner is the Social Security Administration Body of Health, BPJS, Kesehatan, Indonesia, for its National Health Security Program.
okay, next slide. So that is actually because of the innovation, and we from deficit then to be positive and many things change. Okay, next slide. So now we have the middle missing. Next slide. So this is how the strategy to recruit the missing middle, especially for the rich. The rich, we have to have public-private partnership for insurance working together with commercial health insurance. So Pak Budi Tambu Polon, we can work together with the COB, coordination of benefit. Next slide. So that is the contributory collection mechanism. Usually we only have achieved 60%. So now we have achieved more than 90% of contributory collection rate. Next slide, please. So this is, how the premium payment channeling, more than 955,000. Even 10 type of channeling, I cannot mention easily. This is almost 1 million. Next slide. So the conclusion is that it is very important should we have strong political commitment to achieve universal health coverage through a single payer scheme for the whole population in 17,000 islands. Then JKN program is marked with numerous challenges and since it is exception, of course, but we are lucky because Prof. Hasbullah is successfully provocator, and also Bu Peggy also have to find out the contribution. Then BPJS Kesehatan is committed to adopt the policy changes, innovation through digital system development, service excellent improvement, and cost containment in order for sustainability of the JKN program after now we have the asset as positive asset. I think that is all. Sabana, thank you very much for the time given to me.
Thank you, Dr. Ali, for the amazing presentation. And once again, your achievement out of 168 as one of the best case studies, you deserve all the applause today. So I'll move to my next presentation. The next speaker for today, we have two speakers for this session. We want to hear the angle of the private sector as well. So let me introduce our speaker, Mr. Budi Tampu Bolon. He will be online. He's not here in person, so we'll be hearing him online. He's the chairman of Indonesia Life Insurance Association and the chief executive officer for Mandiri in Health. He's an actuarial analyst. He's basically graduated from France as Bachelor's of Applied Mathematics. And his experience has been in the actuarial sciences and actuarial industry. So over to you, Budi. I hope you can hear us.
Yeah, loud and clear. Thank you very much, Shabana.
Great. Thank you. Budi, over to you.
Okay, thank you. Can I have my slides, please? Hello. Is my slide already up? Yeah, okay. Okay, so thank you very much to the organizing committee for inviting me, and I would like also to take this opportunity to greet Professor Hasbullah, Professor Gufron, and Ibu Becky. Selamat siang, Bapak Ibu. Allow me to represent the Indonesian Life Insurance Association as well as the company I am working for to share with you some numbers about the private health insurance figures in Indonesia. So next slide, please. I think next slide, please. For Indonesia, I think Prof. Hasbullah, Prof. Gufron has mentioned about our country. So I will not talk much about this, except that probably density-wise, about 60% of the population live in the Java Island, which is only the 5th biggest island in Indonesia. So that is also impacting the insurance industry because many agents, many business are coming from Java Island. Now about health, next slide, please. Indonesia health expenditure steadily increasing, dominated by the spending from government side. But allow me to share with you about the figures, the health expenditure from private sector. So it's only 5.04 billion US compared to 45.2 billion US. And from this 5.04 billion US, we can see that the portion from private health insurance is not yet that big. Last year, 2 years ago, it was 1.3 billion US, but it's increasing. Next, please. Just for our information, in Indonesia, there are 2 types of insurance license, which is life and general. And interestingly, health insurance can be underwritten, can be marketed by both types of insurance company. So both by life and general. Yeah, and we can see that 2022 premium volume, premium amount for life insurance industry, it's about slightly below 13 billion US, while for general insurance industry, it's slightly above 6 billion US. This doesn't mean that it is all for health, but this is the total premium income for life insurance industry. Next slide, please. I have shared with you for the premium volume. Now, how about the claims and benefit paid by life insurance industry? As we can see here, the claim amount or benefit amount, I would say overall it's increasing. Yeah, and last year, 2022, the 61 life insurance companies paid out claims and benefit for 11.6 billion rupiah. And if we try to take a closer look into this 11.6 billion US dollars, sorry, then slightly above 1 billion US, it's for health claims. And in Indonesia, we differentiate between individual health policies and group health policies. So it's still the claims still dominated by the individual. Yeah, but overall we can see that the claims amount increasing. Yeah, and related to COVID for the last 2.5 years, even though our government covered all medical treatment expenses due to COVID, but insurance industry still also took part of the claims between March 2020 until December 2022. Life insurance companies paid almost 700 million US for claims related to COVID. Next, please. How about the number of insured persons? As we can see here, number of insured persons For many years, it was roughly about 62 million persons. But last year, we have seen a significant increase in number of insured persons. And if we take a closer look, the increase are coming from both individual policies as well as group insurance policies. And very interestingly to see that while for many years we couldn't reach the 20 million individual policies, just last year we have seen total individual policies at 28.45 million individual policies. So this is a significant increase, and we believe, later we will see together, we believe that even though there are so many negative impacts caused by COVID, but to insurance industry in Indonesia, particularly one of the good impact is that public awareness to have insurance coverage has significantly increased. So next, please. How about Mandiri in Health? Mandiri in Health, we are a life insurance company, so one of the 61 that I mentioned earlier to you, but unlike our other life insurance friends, Mandiri in Health is focusing very much on group health insurance. So 96% of our total portfolio it's for group health insurance. So next, please. And because we focus a lot on this, then until today, Mandiri in Health has maintained its position as a market leader for group health insurance. Not for all lines of business, but for group health insurance, we have a 35% market share in the Indonesian life insurance market. And on the right side, we can see that premium volume for life insurance industry up and down, and last year was not a good year. But for Mandiri in Health, we have seen our premium income steadily increasing, and we believe that public awareness for health coverage has increased. Next, please. This is something that we continue to monitor, ladies and gentlemen, which is the out-of-pocket expenditure. In Indonesia, out-of-pocket figures, it's still pretty high compared to some other countries. So we believe that this is a good opportunity. Prof. Hasbullah has also mentioned earlier, this is a good opportunity for Mandiri in Health for the future. Yeah. And next slide, please. We can also see that medical inflation in Indonesia is one of the highest. So that high out-of-pocket ratio combined with medical inflation, which is still high, we can forecast that in the coming years, out-of-pocket ratio will not reduce significantly yet, and this represents a good market for us. However, next slide, please. However, Prof. Gufron has also mentioned that in order for the 61 life insurance companies to boost the sales of health insurance products, in many cases, clients or customers always ask for a coordination of benefit because they feel that they have paid their contribution to our Social Security program, JKN, explained by Prof. Gufron earlier, so that they are looking to have a product that can be a combination coverage between our Social Security program and the private insurance program. Last year, we saw more than 100,000 inpatient cases. Slightly below 20,000 can be or can fall under the coordination of benefit scheme with BPJS Kesehatan led by Prof. Gufron. And if we convert this number of claim cases into amount of claims, then we can see that Mandiri in Health and probably some other private insurance companies can recover roughly 25% of the claims amount from BPJS Kesehatan. So this will help the loss ratio for health portfolio to be lower, to become lower. And when the loss ratio for health product becomes lower, ladies and gentlemen, then normally a premium, either for new products or at policy renewal time, will be lower, will be affordable. And when premium is lower, more affordable, then hopefully the density or the penetration rate for health insurance in Indonesia can become higher. And hopefully within next few years from now, the universal coverage, as explained by Prof. Hasbullah earlier, can be achieved in Indonesia. I think that will be the end of my presentation. So as conclusion, private insurance companies coupled with the support or coordination of benefit from BPJS Kesehatan can help reducing the out-of-pocket for some Indonesian people when they need medical treatment. Thank you very much, Shabana.
Thank you very much, Mr. Budi, very invigorating presentation. And now it's open for question and answers. If you have, please, can we have the microphone?
Thank you for a very interesting presentation. My name is Rajiv Sadanathan from India. Couple of questions. One is, in one of the problems that we have faced while trying to cover the missing middle is, if you don't make it mandatory, there is a possibility of moral hazard with the people who need insurance buying it and others not buying it. So I'd like to know how Sri Lanka, how Indonesia has kind of got around that issue of voluntary selection. Some more questions coming. Second one is that Mandiri claimed that there's a demand for health insurance from the lower income groups, which would be intersecting with your target group, isn't it? So what we have seen is that it's quite possible that where they feel that the coverage is not high enough, they might be buying it as additional insurance. Is that what is happening? And third comment is I don't think you need to be worried about the medical inflation, because where the coverage is good, cost of healthcare will go up. That's going to be a problem in the long run, but I don't think you should see it as a bad sign. But when you compare the experience of Thailand and China, what Thailand did smartly was to put a cap through the global budget, which China did not do, and you can see the consequences on the way the health expenditures have gone up, and maybe that's something that possibly Indonesia could look at. Thank you.
Thank you so much, Rajiv.
Can I answer directly?
Yes,
Okay.
please.
First of all, about thank you for your genuine questions. But 3 questions is look like examination. Oh, 2 questions. Okay then. So number 1, Rajiv.
We'll take your questions.
Yeah, about the mandatory. We that time discussed with him and with other colleagues 2 years just to decide whether it is mandatory or voluntary. Yeah, but finally then in the law, it was mandated that it should be mandatory. Without mandatory, even mandatory, not yet cover 100%.
Even for missing middle?
Yeah, even for the missing middle. Yeah, for everyone, even for the foreigners, as I mentioned, if they stay in Indonesia more than 6 months, they obliged actually to register. And there's number 2 about the
private and these two coming together, the intersection between them.
Yeah. No, actually for the poor, they are not the target of
Mandiri.
Budi Tamu Polon for the commercial insurance. Usually commercial insurance for those who are working in the company or for those who are rich, who are not satisfied with the BPJS Kesehatan. And I work, now Bu Becky work in the commercial health insurance Pak Budi mentioned. Then number 3 about the medical inflation, cost control, medical inflation. So in Thailand, as you mentioned, there is a cap, but Indonesia, there is no cap. So as far as it is medically indicated, it is covered if it is necessary. So even the heart transplant or whatever, it is covered. But of course, we have to define what is the basic medical need. This now we are discussing. Okay.
Yes, we have more questions from this side, and there's another question from that side, so we'll just alternate.
Thank you.
Can you please introduce yourself and your organization?
My name is Chidumga Ohazurike. I work with APS Associates in Nigeria. So Nigeria has a very vibrant private health sector, but a very poor insurance culture. So my questions would be how he said for the private insurance that they target groups. So I wanted to find out how are those groups organized? What is the organization of that group? Then for the products, how do they sell the products? They sell it as a standalone or as an add-on with the life insurance.
So that's a question for Mr. Budi. So can you take those questions? I hope you heard them. Dr. Budi. I call doctor everybody. So Mr. Budi. So
first of all, I don't have the luxury to be a medical doctor, but thank you, Shabana. I may not have heard all the questions very well, but part of it I heard. And in case my my reply is not satisfactory yet, can you please remind me part of the questions that I haven't answered. So basically, in Indonesia, about private insurance, as I mentioned earlier, there are two types of product, which is individual and group health insurance. The company where I am working now is doing only group health. So what we do is that our distribution channel colleagues, they go from time to time to companies, to organizations, to offices, looking for group health insurance. Yeah, so what we do, it's basically B2B, and those companies, those organizations are essentially based in Jakarta, in Surabaya, the big cities in Indonesia. And of course, Prof. Gufron has mentioned, those companies are required to take part, to be member of JKN, BPJS Kesehatan. So meaning that they have extra budget to pay for additional or top-up benefit to their employees and families. So I hope this answers. Now, how about the individual health insurance products? Well, basically the individual health insurance products in Indonesia are marketed, our two main channels in Indonesia, it's either agency or bank assurance. So knowing that individual products basically sold by agents or bank assurance officers, so honestly speaking, they are looking, those marketers, those sales force are looking for some incentive, sales commission, etc. So they are targeting to people who have money, who are of some or certain social status, etc. So this is, I think, our next homework. We have seen that number of insured persons, particularly the individual, has significantly increased. But essentially, those new customers live in big cities, while probably in some other medium size or small cities, there are some people looking for additional health insurance coverage on top of the BPJS Kesehatan program, but they don't have access yet or sales force from private insurance companies do not go there yet to small cities. Hope this answers to your question.
Thank you, Mr. Budi. We have another hand, and then I'll go to you, Angela. Here. After Angela, then I'll take your question.
Thank you very much. My name is Abdul. I work for Abda Associates. So my question goes to the first presenter, Professor. I mean, it's so good to see that the coverage level is actually that high. But I'm a bit worried because it's a contributory scheme, and this means that people contribute and then they are covered for a particular period of time. And I don't know if you have any strategy in place to ensure re-enrollment after a person's coverage level has expired, so that we're able to maintain this high coverage level over time. So if you can just shed some light on it. My second question is regarding the contribution itself. Can you tell us how much the premium cost is? And secondly, with regards to the premium, we know that you have a formal sector and the informal sector. But for the informal sector, and like it's obtainable across most countries of the world, income levels are usually different for people in the informal sector. Is all informal sector actor expected to pay the same premium level? Or do you have a particular, do you graduate this premium level for informal sector? You can shed a bit more light on that. And then my third question is with regards to coexistence of a government or a public health insurance system and a private health insurance system. In most countries where they've moved to establish this big, broad government health insurance system, there's usually a lot of kickback from the private, and private see it as sort of a competition kind of a thing with government. And would like you to shed a bit more light, because the last presenter showed, what he presented showed some sort of good harmony, and the fact that you're both looking at out-of-pocket expenditure. What are some of those policy levers that exist within this government legislation for health insurance that makes it easy for the private sector to actually collaborate, to participate in this space at? Thank you.
Thank you so much. And over to you, Dr. Ali, Professor Ali, and Mr. Bolan, Tampu Bolan. So can you, he asked 3 questions. What is the coverage after the expiry? The second was about the premium. I think Professor Ali displayed a slide with the different premiums according to the income. He had a slide on that. And your last question, coexistence of the public and the private financing, health financing or health insurance system. So 3 questions for you, and I think probably you can go and take a look at them first, and then we'll go to Budi for his answers.
Yeah, I think about the strategy for the collecting contribution, as I mentioned, we have too many strategies, maybe more than 3 hours if I explain. So basically, one, we use working with the many channels of payment. For example, with the bank, the important that the person has to have the money in the bank. Then this auto debit. So auto debit, automatically they will pay, deducted to pay to BPJS. The problem is they have no money in the bank, but we have we call it cadre, JKN cadre. So we with the cadre and we pay the cadre. So the cadre have collect the money from the farmers, from the from many candidate of our members, and many things actually. So for the formal sectors, the employer pay 4%, employee pay 1%. But of course, for the poor, the government who pay around 42,000 rupiah, meaning around $3. Around $3. So $3 each. But for those informal sectors, depend on what type of work. If they want very expensive one, it is around $10 per month for individual, something like that. It is clear?
And the last question was the coexistence of the public and the private health insurance.
Yeah, it is very important, as I mentioned, because it is compulsory. So the whole population of Indonesia actually should also be obliged as the member. But anyhow, and we are not competition with Pak Budi Tambu Balon with, in fact, you know, PT Askas, the BPJS Kesehatan actually, who established and developed in-health the time. So we developed the private one. But then now we are working together. Those who are not satisfied with BPJS Kesehatan, then they not competition, but they can have what to call it, additional to the private insurance.
Thank you so much. Is there anything to add, Mr. Budi, online? Or should we move to the next
Thank
round
you,
of
Shabana.
questions?
I think I would like to add on the last question, the third question is that it is true that Mandiri in Health used to be one of the divisions under BPJS Kesehatan when it was still called PT Askes Persero. But what I would like to say is that the first time BPJS Kesehatan was launched, number of premium volume, number of insured persons for group health decreased. It is true, or it was true. But for the last 5, 6, 7 years, as the graphic has been shown to you, that number of insured persons has steadily increased. So in my view, representing the life insurance industry, there is no competition between private and public sector here. Yeah. Instead, the way we see BPJS Kesehatan, BPJS Ketenagakerjaan, they are helping BPJS, helping the private sector in increasing the awareness of public to have protection. Yeah, so one of the challenges for many years for private insurance industry to grow is public awareness was low. But thanks to BPJS Kesehatan, public awareness has increased significantly. So we don't see any competition between public and private. Thank you, Prof. Gufron.
Thank you, Angela. Please.
Sure, thanks.
It's working.
It's working. Can you guys hear me?
Yeah.
Thank you, Angela Nachanzi from ThinkWell Uganda. Thanks, Shabana. And to just start it off where we have ended, the interaction between a private scheme and a public scheme. I know the challenges we are having now is that there's a strong private lobby that doesn't allow you to progress the public scheme because of the business. So I'm happy to learn that there is no competition. I want to think it is implicit that it is there. I'm just trying to imagine. I know there are people who have a public cover because it is mandatory, and then a private cover as a top-up. So if I went to a facility that has both a public cover and private cover, what would be first charged? Because I know private insurances usually want to first exhaust everything from the public cover, and then they only take the surplus or what is left to the private cover. Is that a situation we are seeing in Indonesia? What are the payment provider mechanisms between BPJS and the private insurers? Are those trying to kind of be aligned? Because if I am a provider and I have 2 insurance covers and someone comes in, I will drive them or steer them to where I have a better payment mechanism as a private provider to maximize on profits. So those kinds of dynamics would be interesting for us to learn. Thank you.
Yeah, thank you very much, our colleague from Uganda. I think, of course, actually,
it's not working.
The battery.
Yeah, it's working now. Some technology.
Okay, I think that BPJS usually pay first, but of course, sometimes the policy changes. So in our opinion, actually, at least my opinion, no need, we always first payer. But yeah, usually we are the first payer. Then the in-health or other type of commercial health insurance, the remaining. And again, I think for the way to pay to the private hospital or private, private healthcare, for private healthcare, we use capitation. And we have two types of capitation, performance-based capitation and risk-based capitation. So for the risk-based capitation, those who have higher risk, we will pay capitation more. And those who have performance, with the 3 indicators, then we will pay more if the performance is better. But for the, those who has the commercial health insurance, for example, now we allow them to have private, like executive clinic. So they can go to the hospital directly, maximum pay 400,000 rupiah, maximum. And then if they are not satisfied with our class and they go to the rise to executive class, then they have to pay the difference, something like that. And the difference previously we make maximum, but now no more maximum. So depend on the arrangement between the hospital and the commercial insurance.
Thank you so much. I think it's just a top up for the, the private sector is a way to top up the services, have a better outlook in those executive facilities. I move, we have a question from this gentleman, please.
Thank you. I'm Nur Nobi. I'm a PhD student from University of Strathclyde and a health economist from University of Glasgow, and I'm from Bangladesh. Okay. So I'm just wondering to know about how Indonesia developed the system and maintaining the system to collect the contribution from informal sector. Because they frequently changes their profession and their places as well. So how you develop the system to manage this kind of population in terms of accumulating them and collecting contribution from their side?
Right. I think it is the most challenge of our program because we have a huge informal sector also, like in Bangladesh. And, the way to recruit, there are many things. So first that we have what we call it PCR, actually trying to mapping, which is those who are not informal sector, not yet as our member. Then we work together with the Minister of Village, those who are dealing with the villages. So we work and the government pay the money around 1 billion rupiah. So the 1 billion rupiah, I cannot calculate it in the dollar. So with that money, so one of the money is used to mapping, and then we trying to search those who are not yet covered. And that will inform us, and then our cadre or maybe our staff will go and then identify. So if this person are poor, then will be paid by national level in the Ministry of Social Affairs or in the local level government. So if local government doesn't pay, and it's depend on the person. So therefore, we still now having around 8% of the missing middle. So this mostly are informal sector. And of course, that informal sector sometimes, as you mentioned, not sustain in paying the premium. So in that case, we have many type of new innovation, how to remind. Even we automatically calculate how your ability to pay. So if your ability to pay is such amount and you would like to installment, then it is okay. And we will help them, something like that.
Professor Ali, thank you so much. I have a last question for you before we break up, before we have the next session.
The examination or what?
No, it's not the examination. I am very interested in the Indonesian health insurance model. So what I wanted to understand, and that's a follow-up with the question the gentleman had. So do you have the digital data for informal workers? One. And second, I would want to understand, because when you were talking in the break, the governance system of BPJS, does it come under the Ministry of Health, Ministry of Finance? And you said it's the president. So I just wanted to understand how that works, because countries like ours, the health insurance schemes sit with the ministries of health. How were you able to move, and what was the reason that you moved the whole management and administration from the Ministry of Health to the president's office, and why?
Right. First, that time we were confused whether we will go to the contributory system or non-contributory system or tax-based system. But with Pak Hasbullah at that time, and he was very active. So because at the time in Indonesia, those who has tax number is very limited, less than 3 million. We have more than 200 million people, but only 3 million people who has tax number. So it is impossible if we go to the tax type of non-contributory system. So therefore, then we, of course, it is better to use contributory system. So then to contributory system, of course, it is not easy because the money is not from the government. Actually, the money is from, from the people. So the money is belong to the people, and we given we call it in Indonesia is the amanah, is the trust. So therefore, the money is the trust fund. So the money belong to the people. Because it is belong to the people, and we have 255 million people as the beneficiaries. If we have responsible to each of them one by one, it's difficult. So therefore, we have to responsible to the president. Yeah, that is actually the behind that. And of course, because now it's interesting, Minister of Health are interested also that we have to under him. But if under him, it means the money is from the government. So of course there is money from government for the poor, but we identify first the person. If the person is there, then the money from the government come. So again, so basically by constitution, the money is belong to the person. So and then paid to the BPJS. And even the government employees, that is the same as the formal sector non-government employees, where the employer, the government as the employer who pay 4%, and the the government employees who pay 1%. So all the money is again belong to the people, not belong to the government, or not belong to the commercial or company.
Okay, so I get it. So the reason why it was under the president is that this money is not the government's money, it's the population's money, and they're responsible as amanat, we call in Urdu, and you amana in Indonesian. So it's a trust that is there with the government, and the government is not just the health ministry, which is supposed to implement it, but not as a trust, which is kept with the president.
And number two, we are not only working with the Minister of Health.
Yeah.
We are working with the Minister of Finance, who always make, how much operational cost. They always make, permission from the Minister of Finance, and we have to report every month. And not only Minister of Finance, but also Minister of Home Affairs. So the president issued presidential decree, the first presidential decree in the year 2022 is about optimization of national health insurance. That 30 ministerial and also institution have to work together with BPJS in order to make sure that the universal health coverage can be achieved in the year 2024.
Thank you so much, Professor. If you have, I'll take your last comment because I have another panel waiting.
Yes. Okay.
Thank you so
Just
much.
want to explain the basic principle why this BPJS is a public funding. In the transaction, actually, we have two different transactions. One is the public one, which is mandatory. It is tax system. And therefore, in the US, the Social Security, like JKN, it's called Social Security tax. Everything which is mandatory cannot be managed by private sector. Private sector manage fund for the voluntary transaction. with company, corporation, whatever. But in Indonesia, if we use the public as a government, we have problem with the bureaucracy, administrative and finance bureaucracy that can limit the dynamic, the innovation. And therefore, we set up a parallel or quasi-government entity. We call it BPJS. This not company, not corporation, it is public entity. It's parallel with the government, but it is exempted from the government's bureaucracy. And therefore, they have a more flexibility to just funding. So that's the principle why we separate it. Because of the president is the responsible person for the countries, this, as Pak Gufron mentioned, entity, BPJS, work with various ministries, various organizations, must be controlled or responsible to the countries.
I think that's a good point, because the convening power of the health ministry is not as much as you have the president's office convening, and that's what we've seen in our work.
I do not know. Next time, if Pak Hasbullah to be the minister, maybe will change.
Thank you so much. Thank you for all the speakers for this second session. It was really, it was really exciting to listen to you, and Budi, thank you so much for that. And our final session is a panel discussion in which we have 3 panelists. We have 1 panelist who is in person with us and 2 panelists online. I'll kindly introduce all the 3 panelists for today's session. The session is on health system strengthening in the aftermath of COVID-19. How have the health systems responded, the challenges that they had, the opportunities after COVID-19? My first panelist is Anastasia Susanto. She is currently the Health System Strengthening Lead for USAID's Indonesia project. She has more than 15 years of experience which includes health financing, information systems, HRH, etc. She's currently leading USAID's MNH and TB strategic health purchasing efforts in Indonesia with the Ministry of Health and the National Health Insurance Agency, and also supports Indonesia's digital transformation efforts. My second panelist for today is Dr. Anuradha Jain. Thank you, Anuradha, for joining us virtually. She's a clinician with formal training in public health, and she has served in various prestigious national and international organizations. For the last 8 years, she's been working with USAID India and providing strategic oversights to USAID's largest health system strengthening portfolio and COVID-19's pandemic response support to India, which is over $200 million. She leads USAID's efforts on integrated program for CPHC at national level, the regional and the global level. My last speaker in the panel is Dr. Carlo Pinello. He is the professor at Department of Clinical Epidemiology and teaching clinical economics and health policy and research methods. He's concurrently serving as the chief of party for USAID's Protect Health, implemented by Palladium LLC. Thank you very much for the panelists for joining in the session. May I request, Susanto, can you come here, Anastasia, so that we can have a discussion? She has been joined virtually by 2 panelists, and I'll be sitting with you. I hope this works, or we can have this. I'll start.
Maybe use this one better.
Does this work?
Yes.
Okay. So I'll start with Dr. Carlo. So Dr. Carlo, I just wanted to understand the challenges that the health system in Philippines, where you're working currently, encountered in the wake of the COVID-19. What were the challenges that you faced in the health system in Philippines?
Thank you, Shabana. Good morning to everyone. I could probably capture the Philippine experience into 3 points as far as its impact on the health system and the challenges that we faced. First is that obviously our systems and capacities were overwhelmed by a pandemic at the complexity and scale that is COVID-19. Unfortunately, the Philippines was unable to build sufficient safeguards despite prior outbreaks of SARS and MERS in the past, since these were readily contained. And unlike in other countries that had more severe impacts of these prior pandemics, there wasn't really that much of a response to build up resilience. And we obviously paid the price for that when COVID-19 came. Second is that our fragmented health system, owing to the devolution of health services back in 1991, where basic health services were assigned to local government units that are autonomous from the national government, made it difficult to coordinate the actions and enforce the standards as we proceeded with our pandemic response. And perhaps the last one is our realization that the health system itself has very limited capacity to actually reach and inform the public and effectively change behavior. And in the context of the Philippines, this could be in the context of a double whammy of very liberal availability of information and the limited literacy and critical thinking capacities of the population that made it a hotbed for fake news and other misinformation that happened during the pandemic. Let me stop there and carry on the discussion later as we hear from our other panel members. Thank you, Shabana.
Thank you, Dr. Carlo. So I moved to Anuradha. Anuradha, what was the Indian experience like? Because we've been following India like the US. India quite succumbed to COVID-19 and it had a lot of cases of COVID and quite a lot of vulnerability. What were the challenges India faced during the COVID-19 pandemic?
Thank you so much. I think I'll start with the challenges, and you very rightly pointed out in the last session that the Chinese have a sea with challenges coming with opportunities. So our challenges came with a lot of opportunities in this country, and I would request people to understand that since we are the largest democracy and the largest population, it's not easy sometimes with a lot of good health systems that we have and a lot of good policies that we have to still take advantage of it. And that's what the pandemic came with. So I would divide the challenges into 4 C's. The first one, I would call it a chaos and lack of clarity. The chaos was because there were multiple sources of information, but the evidence that has to flow to create quick policy changes and regulatory changes was not available, and it is not because the systems don't exist, but it is because it was a situation where the response was probably not that quick because of our enormity in terms of our sheer numbers. And the second one was that we have a very vibrant public and private sector. So the regulatory systems were not ready at that point of time to look at both the systems and take care of the service delivery through both the systems in a very synchronized manner. So that created a lot of chaos in terms of service delivery and a lot of myth in the public on how to, take services and where to take services from. Nonetheless, the second issue that came very clearly was the competencies, as the previous speaker also has talked about. And that was the competency not in terms of a lot of primary care, but it was competencies in terms of more secondary and tertiary care as it was visible during the second wave very clearly. The third piece I think I would focus would be on the continuity of services, and that led to the backsliding, even though we had a program on primary care ongoing even before COVID, which is worth $850 million. But still, all that workforce was absorbed in secondary and tertiary care. And the basic services in terms of RMNCH, immunization, family planning, TB, HIV, got hampered for nearly 4 to 5 months at a stretch, and which brought us down in terms of some of the achievements that we had made. Last but not the least would be, I would club it under the community. The community was in a chaos. And as again, the previous speaker said, the social behavioral change activities, the use of, the local institution to calm down the communities, to spread right information, to decrease the amount of myths that was going, to control the social media. We feel that those were the problems that were happening, and the communities were not very engaged. Our intersectoral convergences were not very effective. The usage of NGOs, private sector partners to work with the communities was in a chaos. And I think all this chaos was added up because our digital infrastructure, even though it was very developed, but was not optimally being used. And it was in a fragmented manner that the digital systems were performing. And that's why I say it all came as an opportunity to us, and we all harped upon it, and the national government and the state governments also took advantage of it. I would stop there and maybe upon it in the next part of your question. Thank you.
Thank you, Anuradha. I really like your 4C model about chaos, competencies, continuity, and community. Thank you for raising all of those important points. I move to Anastasia, and I would want to ask you about the Indonesian experience and how was Indonesia? I know it has been pretty bad all over the world, but how was Indonesia, and what challenges did you face during COVID? What emerged and resurfaced during those times?
Thanks very much, Sabana. It's a great opportunity for Indonesia to also share our experience here. All of the components, I think India and Philippines have highlighted, but the one thing that we learned is fragmentation, not just in information system, but also between human, animal, and environment. There's a huge fragmentations that we see because each of those systems are not talking to each other. So we were not able to identify quickly, is there any anomalies in the public health system? Is there any issues from animal health that affects the human health? Looking at as well from the example, I think during COVID-19 and then after COVID-19, maybe an example from the during COVID-19 as well on the fragmentation part is the difference between, because Indonesia's decentralization context, the national, the provincial, and the districts as well, how those attentions, how harmonizing all of that has been an issue as well. So we do need to have like one command center that provide those guidance in addressing, responding, and managing all of the cases and the response as well. After COVID-19, I think an example that I learned from our global health security colleagues is that during COVID-19, resources were mobilized. Existing resources or budget or also new resources are all dedicated to support the COVID-19 response. One of the budget cut was vaccines for animal, for rabies, for example. So after COVID-19, we found that the dogs are not vaccinated. So there were increasing rabies cases that was then transmitted to humans. So those are, I think, some of the fragmentations and management challenges that we observe during COVID-19 and also post-COVID-19. The other part, I think, the challenge that we also observe is the financing part of it. We learned that for human health, we have BPJS managing the human health, ensuring universal health coverage. But for animal health, for global health security funds in Indonesia, we don't know the landscape. We don't know whether we have enough allocations or not, whether it's sufficient to support the whole system so that One Health can be achieved. So I think that's additional example from me.
Thank you, Anna. There's no problem with the mic, it works and then it stops. So it's up to IT just to check it. So I completely agree. The concept of One Health has been highlighted and resurfaced, which earlier the health systems were not working on. And I think it's a point to wonder that the concept of One Health in light and wake of COVID-19 needs to be strengthened. As you said, and you gave an example.
Your mic is not working.
My mic.
The panelists won't give you.
Sorry. Is this working now? Sorry, I was just saying that Anastasia brought in the concept of One Health, which is important, and that needs to be given importance, because the rabies example that she did and she talked about is important, and we have to look into the light of One Health as a concept, and health is just also beyond health, water and sanitation, housing, poverty, economics, everything wanders down and boils down to health. Moving on, you've talked about, and the panelists have talked about information asymmetry, right? Which created a C for India, like a kiosk for India, and all the panelists have talked about it. I just wanted to deep dive into the information symmetry angle for each of your countries quickly before I move into opportunities. So I'll start with Anuradha. Anuradha, what was the information asymmetry look like for India, and how did it impact the COVID-19, as a country? And similar questions for Carlo and Anastasia going forward.
The information asymmetry, as I would say, is that we have a very centralized system of collecting information at this point of time. And what COVID required was a more decentralized system with more decision-making at the decentralized system. Just to give you a very small example is how we solved it, and that would give you a glimpse of how things were not working that well. So we created, as you said, we supported the government of Maharashtra create a dashboard. And this dashboard was collecting real-time data of 15 days of the number of cases, the trends, and the deaths, the mortality, morbidity that were happening in different districts. And we were getting this data, and then with the help of predictive analysis, we started analyzing the increase in the number of cases that would happen, the kind of beds or the kind of infrastructure and service delivery support that each of these district and sub-district would require, the kind of oxygen systems that we would require, the kind of supply chain management that would be needed, and the human resource that would be needed. This very simple predictive analysis started helping the state and the district and the sub-district level to tackle their challenge. And this was a very simple dashboard, no AI, nothing, just a simple analysis to be done, and that's it. So what I'm trying to explain here is that it was not the lack of data in our system. Our system gathers a lot of data, but how the data flows, where it is used, at what level the decision making has to happen, vis-a-vis, a centralized system where it all gets collected, cluttered, and doesn't make much of a sense. is the kind of asymmetry that we are talking about here. And the second is, in general, the health systems and the health system data flow, which is a lot to do with data integration in terms of our larger services, which is RMNCH, family planning, TB, HIV. So we talk of a family care model, but we don't talk of a family stack that we need to develop to understand what the family issues or what the family health look like, and then what the community health look like, and thus how would you address some of these pieces in a large country like ours. So I would stop there and maybe if you have follow-up questions.
Thank you, Anuradha. And moving to Dr. Carlo, could you just highlight how the information asymmetry, especially at the demand level, I should have qualified my question, the information asymmetry at the demand level, vis-a-vis, I think Anuradha has spoken about the supply level information asymmetry, and the data was fine. But what about the demand side? Because when I see the countries and the data, there was a lot of information asymmetry at the demand level. Was it the case in Philippines and Indonesia, and how did you, address that? Dr. Carlo?
Yeah, thank you, Shabana. Before I go to the demand side information, I'd just like to follow up on the point raised by Dr. Anuradha about the fragmentation of information sources and the difficulty to aggregate. As a decentralized system, that was also the difficulty that we encountered and continued to struggle all throughout the pandemic, actually, being able to collect enough information and aggregate them and be able to report it on time as well. And then cleaning that data over time. So it was also a bit confusing when the Ministry of Health would sort of like recalculate the actual numbers after several days. On the demand side, this was really tough because the information, given the availability of social media, was diffusing very fast. Unfortunately, there's no distinction between correct information and misinformation, or even just plain speculation coming from people on how to deal with COVID, which admittedly, we also hardly understand, even in the scientific community. After all, this is a novel disease, so we didn't even know how it was transmitted at the beginning. And so we had to entertain a lot of theories as well as options on how to protect ourselves. The real battle, I think, in the Philippines was not in mass media. The mass media, I think, just amplified what information was actually flowing through social media and informal community networks. And that's something that actually gives us all a pause as to how to deal with information flows at that level and how to effectively address that when the next, health crisis happens. And definitely the public will again sort of panic and grasp at straws in terms of what information can be available. And the lesson I think that the Philippines got from that experience was to really come up with consistent messaging and mobilizing different communication arms, both in the government and the private sector, and even tapping into social media influencers who were supportive of the government agenda to contain the pandemic, to counter the rapid diffusion of misinformation as well in these various channels. Thank you, Anuradha.
Thank you. Thank you so much. And Anastasia, you have the last say in this.
Yeah, thanks very much, Sabana. I think building from what Dr. Carlo and Dr. Anuradha mentioned, in terms of the flow of information, I think at the beginning, we have a lot of parties trying to provide that information. But then along the way, there's one comment center that coming from the COVID-19 task force that the government established that then provide the same information reference for all the others, which will then, allow us to get one source of data reliable for all of the community as well. And in terms of misinformation, we do have, so the government also established a risk communication and community engagement task force that is also the role is to counter if there's any misinformation provided by any other parties. So they provide clarifications. The COVID-19 task force also sometimes issue a fact or misinformation, for example, and using social media like the Philippines are doing. So Instagram, all of those, Twitter, all of those platforms are used to reach out to the hungry, let's say, to the hungry Indonesians, to all of that informations during and also post-COVID-19. In addition to that, the Ministry of Health also established a platform called Peduli Lindungi, which is used by the government to communicate to the community as well on the risks of COVID-19 when entering public areas, or your vaccinations status, for example, or your COVID-19 status. And that platform is used by the government to channel and deliver treatments, drugs, and all of that as well. So it's been very useful for us to reach out and make sure coverage for the community.
Thank you so much. So next round, so I always say when you talk of problems, you'll get more problems, but if you talk of possibilities, you'll get opportunities. And moving to the second round of questions, while we've talked about challenges, what COVID-19 had, my second round is more about the opportunities that have resurfaced for the health systems around these three countries. And starting with Anuradha, what have been and what are the opportunities, are the transformational changes that India is doing after COVID-19? What has it brought to the surface as far as opportunities are concerned? And I have similar questions for Dr. Carlo and Anastasia. Over to you, Dr. Anuradha.
Thank you. Thank you so much. And I think now I would take this opportunity to divide my answer into 4 S. So the first 2 S in terms of opportunity that came for us was to strengthen and support the government. So Government of India post-COVID or towards the third wave of the COVID pumped in a lot of finances into the system, and it came as the Ayushman Bharat Health and Wellness Center was already existing. The Pradhan Mantri Arogya Yojana, which is our insurance scheme under the larger umbrella of Ayushman Bharat, was existing. But what came was our 15th Finance Commission and PM Abhin, which is the infrastructure mission that came in, as well as the digital mission. So over more than few $1 billion were pumped into the system, and these came as an opportunity. And here was our opportunities as USAID to support the government with technical assistance and innovative labs, as we call it, learning labs, because we learn from the system and we try and do some implementational research at a very small scale to then help and inform the technical assistance and support the government. So the opportunities were in the area of lab strengthening, right from the simple lab systems at primary, secondary, and tertiary level to the genome sequencing labs, which were very important through the the COVID period as well as after the COVID period, both in human health as well as zoonotic health, as Anastasia also mentioned, because One Health became a very big agenda along with climate change for us in these times. The oxygen ecosystem, which was developed by Government of India, and we were very supportive of it throughout the COVID period, now has to transform into the health system, and we had to find out opportunities of what was established need to be sustained in these periods. For example, the concentrators, the oxygen cylinders, the LMOs, the PSA plants. There were huge infrastructures that were developed. And it all required money, it all required electricity and the alternate source of electricity. The third thing we realized was quality of care, where a lot of effort had to go, because a lot of mortality during COVID happened because of some of the quality issues that were persistent in the system, and a huge focus needed to go there. The surveillance system as part of the larger One Health agenda, which Government of India was already launching through the Integrated Health Information Program and the earlier erstwhile IDSP. So the surveillance system had to be strengthened both in the rural area and the urban area. Last but not the least, the decentralizing process of both PMFHIM and 15th Finance Commission by bringing in the local bodies and the elected representative and the money flowing through local bodies for health into the system was something new, and it needed a lot of competencies in the local system to use and absorb this money. So these were huge opportunities. Urban health came up as the largest agenda, and we've been pushing for it for a very long time, as USAID, but it got a huge thrust through the new financing mechanisms that came in. And obviously, as USAID, we jumped upon that opportunity to support the government. And last but not, and the second part of it is sustaining and supporting the ongoing program. So USAID had brought in a lot of money during the COVID, and we had started a lot of initiatives that we knew and the government knew were very useful for the system, and we had to sustain these so that it doesn't get lost as small innovations and in small scale. And hence a lot of work had gone in digital health. So those models had to be scaled up, and the government had the ABDM, the Ayushman Bharat digital mission that was coming up. So whether it was small scale innovation in eSanjeevani, which is our teleconsultation work, or whether it was innovations around platforms for our community health officer in the primary care, or the whole primary care work itself was concerned. So these were the scaling up mechanisms that we had to look into. Again, a lot of work from our end had got into immunization, and immunization involving NGOs and communities. And as my previous speaker talked about, the asymmetry of information in the communities, and there was a huge amount of work that had gone in there. Partnerships. We had got in a lot of partners to support the COVID system, and these partners are of huge value in the decentralized planning and action mechanisms for the government. How do we sustain all this? So the 4 S's are the place where we saw the opportunities: strengthening, supporting, sustaining, and scaling. And that's how we intend, and we look at those opportunities to support the country.
Thank you, Anuradha. Thank you so much. This is amazing. And moving to Dr. Carlos for his comments.
Thank you, Shabana. I have sort of like 3 things that stand out when we talk about opportunities arising from the pandemic. The first one is that when the Universal Healthcare Act of the Philippines was passed in 2019, it included language of a whole of government, whole of society approach. And we hardly understood what that meant prior to the pandemic. And we sort of had a what we call a driver's seat view. I mean, everyone had a driver's seat view on how that actually would happen in the context of a pandemic, where a country would literally mobilize all of the resources at its disposal, whether it's state-owned assets or the private sector. So for example, the Philippine Department of Health distributes centrally procured commodities as part of its regular functions. But that logistics system was definitely not sufficient to meet the scale and the scope of operations needed to respond to a pandemic. And so our vaccines and other supplies were actually being ferried by our military and also by the private sector that are beyond the usual instrumentalities that the Department of Health or the Ministry of Health would usually utilize. Another opportunity that arose from the pandemic is a review of our government procurement rules. In the interest of protecting government resources from graft and corruption, we have pretty stringent procurement rules governing how how the government could buy goods and services. We realize that these regulations can sometimes be very restrictive in the time of emergencies, and has actually added, the experience with COVID added to the body of knowledge that would, lead eventually into the move to have these things reformed. Another would be looking at our existing data privacy rules that, would need to be reviewed and revised in order to facilitate the sharing of information, especially in contact tracing, that we haven't thought of at that level prior to the pandemic. So these experiences actually push the society to actually entertain and consider a lot of new and sometimes threatening ideas under normal circumstances, but find it very sensible in the context of responding to a pandemic. And then while I mentioned earlier that decentralization or devolution made it difficult for COVID response, the other side of decentralization and autonomy is also the ability of local governments to be very agile and very innovative in responding to pandemic threats given their contexts. If all local governments were to wait for national governments' guidance, resources, and support, then the pandemic would really run out of control. But you have certain local governments that manifest that capacity to actually deal with the pandemic at their level and introduce innovative solutions. And the third one is also opening the eyes of not only the Ministry of Health, but also of the whole government and even the private sector on the role of social determinants of health in addressing or responding to a pandemic or a public health crisis. As mentioned earlier by Anuradha, urban health used to be like a novel concept or a niche concept in discussions, but the way COVID affected our large cities is essentially a testament to the need to address urban health concerns. And included also would be how we deal with social services when there is disruption of economic activity, because you cannot just keep people at home if they have nothing to eat or they could not get to jobs that would be their sources of livelihood. Or understanding where people come from given their cultures, their literacy levels, their superstitions, biases, etc. When it comes to health. And the inability to connect with where people are coming from is, I think, at the heart of why our messages, right as they may be from a scientific standpoint, would either not be understood or not accepted at all. So thank you.
Thank you, Dr. Carlos, and final comments from you always, Anastasia. What has Indonesia been doing? What is their transformation plan after COVID?
Thanks very much. I think we are very proud to, with this current government, we have Ministry of Health, a very strong minister at the moment that drives 6 transformation pillars in, I think, all of the health sectors, health components of the system. So addressing issues from primary care, from hospital, from referral, to transformation of health financing, health information system, health resilience, you name it. Basically everything is currently being transformed by the government. I think one thing that we are, USAID Indonesia is proud to support is a collaboration between Ministry of Health and BPJSK to look into how we can promote efficiency, accountability, looking at innovative ways to mobilize levers to improve health services, but also to improve behaviors of health providers. So we are currently already piloting a strategic health purchasing for maternal and newborn health. And we are in a process of moving forward with the second pilot, which is going to focus on tuberculosis at a primary healthcare level. So strengthening primary healthcare is a main agenda for everybody in Indonesia. So that's, I think, one area. And I think referring to what you mentioned about navigating political, economical, and social as well, I think the strategic health purchasing efforts we're currently working on together with Ministry of Health and with BPJSK is a perfect example of navigating the political, social, and economical as well. The second part, I think, is related back to the One Health. It's as I will borrow what Dr. Carlo mentioned, an eye-opening as well, I think, for us, is to look how weak our global health security landscape is in terms of financing, HRH, information system as well. I think the GHS landscape is like, I don't know, maybe 10, 20 years behind of the human health. So how are we going to build that is an opportunity for us to collaborate together, building our realization from COVID-19. And I think the last part is the information system. I think everybody is moving into digitizing health. So how can we take this opportunity to move forward, not just digitizing the human health, but also the animal health and the environment health later on, so we can, referring back to the challenges, we can identify the anomalies in public health and we can respond using data to effectively address any future threats. And I think the last part is, I think from the human side, we understand that primary care, we have a different system. There's a primary care for human and there's a primary care for animal as well. And I look forward to be able to visit primary care for animal to see the babies of cats or you know, all of the animals, to see how we can take that and link the two systems to support a more holistic system moving forward. Thank you.
That was a perfect ending to the session. Thank you to all the panelists for bearing the last, you know, being the last speakers in the session. We just have quick, can we take quick 1 or 2 questions? Yes, please. Before we wrap this up, I know everybody is tired and they're looking forward to the plenary.
Yeah, if you're tired, you may not like what I'm going to say. Because I congratulate the 3 countries who have doing very well. Because I was just going through the World Bank report called Strong Advance Early Retreat. Allow me to read from this. After the strong response to the pandemic, health spending is no longer a priority for many governments. In 2022, government health spending contracted from its peak of 25%, only 13% in 2019. The reversal was even starker for the priority that governments gave to health. In nearly half of the countries, the settled health share in general spending fell below the 2019 levels. So I'm so happy that the 3 countries have bucked that trend. Congratulations.
Yeah. So first, I would like to congratulate USAID Indonesia and also, of course, from Philippines and India. So the Indonesian type of approach is using the concept of One Health. Of course, One Health is not only multi, what do you call it? Disciplines approach, but it is actually discipline approach. So it is good, but the question is how in the future, when we are trying to shape better world and future generation is ready with the concept of One Health. Because in the Ministry of Health now also have One Health but different meaning. Satu sehat. It is information system. Okay, this is for the Anastasia, but of course for our colleague Carlo and also Anuradha from India, I think in Indonesia, because when you are talking about asymmetry of information, then we have a PCAP. So PCAP, as I mentioned in my presentation, already connected with more than 23,000. So we can identify who should be vaccinated. And if the comorbidities, who should be prioritized, sing and that. And also as mentioned by Anastasia about the COVID-19 Task Force Center of Information. But then how actually, the time in Indonesia, the Minister of Health and we also working together, have they call it diagnose, testing, then treating, and then tracing with the information system. So I would like to know whether in Philippines and also in India, how having this, how to testing, to diagnose, to trace, and to to treat using what type of information system. Indonesia is lucky because then we work together. We have PCARE already, and then Peduli Lindungi and with many minister.
Thank you so much for the questions, and I'll start with Anuradha and Carlo if they can answer and respond to the questions. I think it is more regarding information asymmetry. I think at not at the demand level, but what did the government do for that information asymmetry? How were they contact tracing? How were they vaccinating? What kind of data existed? If we can quickly, move Dr. Carlos from you to Anuradha, because we need to wrap up the session in 5 minutes.
Yeah, thank you, Shabana. I'm glad to report that the budget for the Department of Health and our Social Health Insurance Agency, PhilHealth, actually increased post-pandemic. So it's in an upward trend. However, comparing it to total national government spending on health during the pandemic period, this would really be, this would be considered a drop. And our projections would be that instead of having reduced out-of-pocket spending down to 45, we would go back to pre-pandemic levels of 48%, assuming that the rest of the government agencies would revert to their usual functions and leave DOH and PhilHealth to attend to the various health concerns, including One Health and building the resiliency of the health system altogether. The information that was gathered during the pandemic period actually went through several contact tracing applications, but these are non-operational now at the moment, and it's actually not being used since the alert levels were reduced, and so we're back to our usual contact tracing systems, although strengthened given the experience from the pandemic. But there has yet to be a formal digitization program for health that has yet to be launched. The new Secretary of Health has identified that as one of his priorities, along with pushing for primary health care and for upgrading our different health facilities. There's also a law pending in Congress for the establishment of a Philippine Centers for Disease Control to handle most of our One Health and surveillance concerns in a more coordinated manner. So thank you.
Anuradha, just quick comments, please.
Yes, quick comment is one, our contact tracing was very robust mechanism. It's an app, and anybody who gets tested positive in any lab across the country, that's on the app, and most of which it is, it would register there, and an automatic system would start notifying the local agencies. The local agencies would then contact the person. The app is still ongoing, and a lot of people who are getting tested are still being reported and recorded. That's one. The second is on vaccination. We have a biggest COVID app that is now being transported for routine immunization, which would be UVIN. And it is one of the most successful apps that the Times have seen. And there hasn't been much breakdowns in it. So everybody who's getting vaccinated, getting registered, the online system informs them through SMS, through IVRS. So it's a very, very robust system. The second part is on One Health. So our data on One Health is becoming robust. So we have, as I said, an IHIP system where we have community surveillance, lab surveillance, and the permanent surveillance through, our facilities. And this is for 30 disease, but very soon it will extend for air pollution, it will extend for climate change, and a lot of other things are on board, which would be data that would be flowing up the system through this IHIP mechanism that I'm talking about. So One Health, and there is a system of IPHL lab, which is an integrated lab at the district level, a block public health lab, and data aggregation system on One Health that would happen. So there's a robust system that is coming up. And as I said, a lot of money has been given by government to strengthen this whole system. So I would stop there.
Thank you, Anuradha. And I think one of the success stories for India was also increased vaccine capacity, which was multifold, exponential increase in vaccine capacity in India. And they had, these vaccines supplied to all over the world. Thank you so much for an amazing line of speakers. And I think we should clap for all the speakers and clap for ourselves that we were able to sit for all the 3 hours here. And I would especially like to thank Eva and Hassam, Eva and her team and Hassam for helping out with this session. And before we leave, all these presentations are available and you can have a look, download them and take it away. And if you want to get in touch with the speakers for more information, they have their emails also written, Eva, so they can get back to them on their emails and try to explore more of the Sri Lankan case or the Indian case or the Philippines case. Thank you so much, each one of you. And I would request the speakers who are here, unfortunately, we'll miss out the online participants for a group photograph before we end this session. We can take and stand over there. And